What now about screening? If you consider to screen this population for too high values of serum cholesterol, for instance, you can make a decision that everybody with a value, test value above 6 on this range of possible scores for serum cholesterol should receive an intervention. If you do this, you should be aware that not even half of all people who are responsible for the over mortality, the excess mortality of coronary heart disease, will be covered by the screening program. And that's because most of the cases they originate from from a relatively large population of people with relatively small, lower levels of cholesterol, and with people with serious increased levels of cholesterol, they are only a minority. And this led to the identification of this prevention paradox. So many people with slightly increased risk yield more cases than few people with a substantial increased risk. And what is this prevention paradox? What good is for the individual, it's not always good for the community and the other people around. For the community, it would be best to approach all those people, also people with only slightly decreased risk. For individual patients, of course, which are in this category, they have profit if they are screened and detected and receive effective interventions. That's the prevention paradox. The individual view versus the community view, and what is the yield of the screening program. We continue with screening for early phases of disease, and one of the criteria that you can consider before you say, okay, I started the screening program. There are 10 famous criteria identified already in 1968 by Wilson and Jungner for the WHO. And this can still be used as a checklist. It's worthwhile to think about screening for this disease, this health problem, and so on. And one of the things that should be known, there should be some insight into the natural cause of the disease on which you want to screen. And this shows a very rough picture and related again to the phases to the types of prevention. Bedankt.
Yo, ga maar. Wil je nou serieus 10 keer het college komen storven?
Ja, maar echt.
Bedankt voor de tip.
Wat zeg je nou?
So, no disease, the onset of disease, somewhere in the cells or something like that, some abnormalities occur, then the phase in which the disease is not visible, so the asymptomatic phase of disease, until clinical symptoms are noticed by the patient himself or by other persons, and from that time onwards we have the clinical stage of disease. This is the normal detection based on pain, complaints, signs and so on, and depending on the availability of a specific screening test, the detection could be advanced until here or here or here. It depends both on the pace of development of the disease, how rapidly it develops, and the type of test and the qualities of the test. So here the domain of the primary intervention, determination of risk factors, tertiary prevention, diminishing the complications of the disease, and early detection and treatment based on the screening and the screening test. And this shows the example that I described a long time ago as an example for screening for cervical cancer. This is a very slow development type of disease. And this is just the average picture for women. So you find the age of women, and maybe if women develop cervical cancer, the symptoms are detected only between 50 and 60. Symptoms are noticed. There's a visit to the doctor, and after some time women may die. But the onset may be already during the 20s or the 30s, for instance, caused by exposure to the human papilloma virus. And here you have the phase in which cells from the tissue, the cancer tissue, are coming loose from the tissue and can be detected by means of a specific test, which is the test of Papa Nicolaus, the pap smear, can be detected in a smear. And earlier we have had a proliferation of cancer cells, so depending on the type of test and development, the pace of development, you can say from 40, 50 years onwards, there is space for early detection, for probably effective screening for this disease. Yeah, very quickly, because there are many words, but here you find the 10 criteria, the prerequisites for screening, formulated by Wilson and Jünger. Only screening for a disease which is an important health problem. What makes a problem an important health problem? A high prevalence, not only in the clinical phase, symptoms, but also a high prevalence in the non-visible stage, the detectable preclinical phase, detectable if a fine screening test is available. And there's also, you can also talk about an important health problem. If the problem has serious consequences, if it remains undetected, or if it is detected too late. Only screen for a disease if there is a accepted treatment available. Generally accepted treatment. What I told, there should be some insight into the natural cause of the disease. The natural cause of the disease should be quite sharply defined. And within this natural cause, there should be an identifiable, latent or early symptom stage. Then the test, there are also criteria for the test itself. So there should be a suitable screening test. And what makes a screening test suitable? It should be valid, it should be precise, it should be simple because you want to apply to large populations of people who are feeling healthy often when you apply the screening test. It should be affordable, acceptable for patients and physicians and so on. So a lot of things which may make a screening test suitable. Then 6, there should be sufficient facilities available for further diagnostic, for definite diagnostic testing. And you can think about manpower and knowledge and skills and so on. There should be an accepted policy about who is eligible to be treated as a patient. If you do the early detection and you start earlier with the treatment, the prognosis should be better compared with the situation before the screening. Otherwise, it makes no sense to introduce a screening program. And further on, 12.9, you can combine this intervention, this type of screening intervention, the COAST and so on, with things that also could have been done with alternative approaches. What is the number of balance? And the final point, the repetition, the periodical repetition of the screening test should be feasible. So that's not about screening as a one-time activity, but repeated activity. These are the original prerequisites for screening according to Wilson and Jünger. We should be aware that application of the same tests can give quite large differences depending on the type of population to which the test is applied. Are you applying a certain test in the open population, which is often the aim of screening, an asymptomatic population, or do you do it in the clinical setting? And the results, if you evaluate the testing, will always be better for the clinical situation. Not because the doctors are better, because they are often experts and things like that, with more facilities available, but are also other reasons why they perform better. Just because if they see the patients of the disease has developed further already, and also what's very important, the prevalence of the disease in the clinical setting is often much higher than the prevalence of the disease in the open population setting. And this prevalence of the disease, or the prior chance to have the disease, is very important for the predictive value of the test. And that's the idea. So the validity of the test can be described and quantified making use of parameters like sensitivity, specificity, the positive and the negative predictive value of the test, the number of false positive, false negatives, the ligand ratios, diagnostic odds ratio, from a table with 4 cells. You can calculate a lot of measures of association between the test result and the true state of disease. You can also see the golden standard test. There are important differences between this open population and the clinical population. In the first place, in the open population, the persons often have no clinical symptoms and feel healthy. So you should avoid to bring them from a healthy condition, at least they think they are, in a disease condition. And associated with that there is often a much lower prevalence of the disease in the open population compared to the clinical population, to which the clinical patients are selected by the general practitioners, for instance. And these are some of the well-known tables that deal with sensitivity, specificity, predictive value. Here we have a test applied in the hospital population. Let's assume that the sensitivity of the test is 75%, its specificity 95%. That means, and the third thing is the prevalence of the disease in this hospital population is 25%. So if you have 400 patients, 1,000 will have the disease. The sensitivity of 75%, that means that the test is able to detect out of this 1,750 with the disease, and the others, 250, are false negative results. And the people without the disease, 3,000, due to the non-perfect specificity of the test, 150 of them will be diagnosed with the disease, whereas it is not present. So these are the false positives, 150. And these are the true positives, the true false negatives, the true negatives. So based on this, we can calculate the predictive value of a positive test result in this hospital population. With a test, 900 are identified, and only 750 of them have the disease. So positive predictive value of 83%. This is quite good, but it all depends on what you do with the negative, the false results. What are the consequences of false positive or false negatives in the diagnosis? False positive, that may be over-treatment or over-diagnosis, making people worried. And false negative, that means that people don't receive the treatment that they may need. The same test applied in the open population, the same sensitivity and specificity, but now the prevalence is much lower in the apparently healthy population, only 2.5%. So out of 4,100, applying the same sensitivity of 75%, the same specificity of 95%, we find a lower number of false positives and false negatives together, 195 and 25. But what is most important for healthcare and also for advisors is not the sensitivity, it's not specificity, it is the predictive value. So here the positive predictive value will be 75 out of 217. Only 28%. If you find a positive test result, you are not even 30% certain that the disease is present. And now it depends on with the rest of the population, and how intrusive the following steps will be. New diagnostic tools, but maybe more risky, treatment when it is not needed. And that shows the difference between screening using the same test in a clinical setting or in a population setting. And screening is most of the times in a population setting. Ben je in de goede groep? We zaten hier met twee verschillende... the other group, they are to the pink, the purple, but I don't know the purple room, which is in, otherwise I asked the person there.
Alright, thanks a lot, I'm sorry.
Dus gaat lekker worden. Kijk eens hoor.
Ook iemand die op seks
Ja, dat
laten.
komt op binnen. Ja, kan niemand zo. Goeie. Ja, goed. Doe wel goed.
Then we have some problems if you want to evaluate whether a screening program is successful. There are three types of biases. I don't know how familiar you are with epidemiology. We often talk about selection bias, information bias, and confounding. For evaluation of screenings, we have comparable things, but now the words, the terms are different. So the first problem is called lead time bias. The second problem is called length bias, length time bias. And then we have which is a type of selection bias, the volunteer bias. And this errors, these mistakes in evaluation research, they can, the consequence may be that you get a wrong idea about the efficacy of screening. First, the idea of lead time bias. In a very schematic approach, here you find again the cause of disease, time of onset. If nothing happens, people die, the time of death, and the time of diagnosis, either based on early symptoms, based on a screening test that is available, and otherwise based on complaints like pain and signs and symptoms and things like that, the normal time point of detection. And this shows a situation, on average, if there is no screening program available, onset of disease, from this time onwards, we know that the person has the disease and there is no treatment, so the person dies several years later. Now the situation of the availability of a screening test, a screening program, which is not followed by effective treatment, maybe because this treatment is not available. It probably becomes the case if you try to screen for lung cancer. And lung cancer has developed all this so far, and the same for pancreatic cancer and things like that, that if you find something, even by a screening test, it's too late. You cannot stop it anymore. So this would be the situation with a screening program. The disease is detected in an earlier stage, but there is no improvement of the mortality rate. So what happens? That the person doesn't live longer, but lives longer with the disease, but knowing that he is diseased. So there's prolongation out of the healthy years, but of the diseased years. And the question is this what you want? And then the third situation, now there's also screening, but the screening is followed because of the early detection. It's possible to have an effective intervention, of surgery or whatever, and that means that years are added to the original years, and only then this screening is effective. This is what we call the lead time. The time for which the disease is, the detection of disease is how to call it, taken forward compared with the normal type of diagnosis. And this is the survival time after detection. So here there seems to be extra survival time from this onwards, moment onwards, for instance, 5 years instead of 3 years here, but the people then become older. They don't live longer, they are diseased for a longer period of time. Only here there is useful extension of survival time. And this is one of the things you have to take in mind. Never use survival time, years that people live after detection of disease, as an outcome measure, a frequency outcome measure, to evaluate the effectiveness of studies. Use age-specific mortality rates, not survival rates. Because here the survival seems to be much longer, but it makes no sense. And that's the idea of lead time bias, if you don't take this into consideration. Additional survival time. So, what is the lead time between detection of the disease based on the screening program minus the time without the screening program? You can also say the maximum lead time is the same as the detectable preclinical phase, detectable based on the screening test, and this depends on two things: the speed of development of the disease, which will be quite different for different diseases. Very fast for lung cancer, or liver cancer, pancreatic cancer, very slow for cervical cancer, for instance. It depends also on the capability of the screening test to pick up early stages of the disease. And in general, you can say short duration of the time of development, the development of disease, and you can say probably the screening will be not effective. If it is a long time, for instance for cervical cancer, screening may be effective, we are not sure about this. And which, as I have shown here, in this case, without an effective intervention, healthy life years are replaced by disease years that people feel, they have the idea that they have been diagnosed, they feel diseased. The first type of bias. And I told also the remedy for this. Of course, you should do the evaluation, but in the comparison of the screened and non-screened population, don't use survival rates, but use age-specific mortality rates. And the second type of bias, when you want to evaluate the efficacy of the screening program, length or time bias. Again, you see the time X, and now we have a number of different cases, and O shows the onset of the disease in a specific case. D, X, again, the detection, identification, according to normal procedures based on complaints, so without a screening test. And here we see some person who needs 5 years to develop from the onset of the disease to serious complaints like pain and so on. This is a slow grower. Here you find something who needs 2 years. And we have more. Altogether we have 20, more or less haphazardly. Some have this development time of 2 years, some 3 years, some 4 years, and some 5 years. What happens if you start with a screening program? Somewhere, the first round of the screening program, somewhere in time. This shows the numbers, how fast they develop. If you decide to start at a certain moment with screening, who are picked up? Not all the persons, and you could do the same some at another point in time. It makes no difference. Of all the people who need 4 years, who need 1 year to develop from onset of the disease to symptoms, the screening test picks up only 1. Those who need 2 years, 2 out of 4 are picked up. Those who need 3 years, 3 out of 4. And the other 3, the slower growers, 4 are picked up. Of the total of 20 patients developing the disease, 14 are picked up, but there is an overrepresentation of the slow growers. And the slow growers are also the patients with the best prognosis. If that may be the case, not always, maybe the clinical phase of the disease shows the same pattern, maybe a linear pattern of development as the preclinical phase. So the screening test mainly detects people who have a good prognosis, and the people with a poor prognosis are not detected. And that's not honest, of course, if you want to say something about the role and the efficacy of the screening test. This shows it now in a different way. Here again, the time, the stage, or you can just think about the size of the tumor. This is the size which allows detection by means of the screening test. For instance, breast cancer self-examination by women. This shows the stage, the diagnosis after symptoms. Here you find the slow growers. You find the fast growers. And the screening is too late. And if you repeat the screening, these fast growers will become interval cancers. They will just be in between the two lines of the screening. And only these will be detected by the screening program. These are so slow that maybe they are dead because of other reasons, because they have really problems with this cancer and with this disease. So that's length or time bias. It's a consequence of the variation in the speed of development of disease. There's an overrepresentation of slow-growing cases detected by screening, and fast-growing cases will be detected more or less interval cases between two screening events. Screening works best for disease with a rather slow pace of development. And how to prevent this bias in evaluation studies for screening? Try to do it based on a randomized controlled trial. So not an observational study. Try to make a randomized design, and that means that the people who are exposed to a screening program will on average have the same speed of development of the disease as those people who are not in the screening part, in the screening arm of the trials. We have volunteer bodies, and that means that those people who participate in screening programs are often different from people who refuse to participate. It's always voluntary participation in screening program based on informed consent and things like that. And what may be the differences? Often people who go for screening, they take care for their health, and they have also, without the screening facilities, more attention for signals that come from their body. They are interested in health and disease in general. They probably will not show that much patience delay. And some people are very afraid that they think there is something they don't want to notice. They don't want to think about this. So that causes patient delay. And this will be especially this patient delay in the same people that don't want to participate in screening programs. And also compliance with respect to treatment guidelines after early detection of, for instance, cancer will be different. What's the consequence here? Subjects who attend screening programs may have a better prognosis irrespective of the efficacy of the screening program due to their other characteristics, which are associated with the decision not to participate or to participate in the screening. And here we have the same solution for the problem in evaluation studies. Try to base it on a randomized controlled trial. Randomized design. Then a few words more about the requirements of the screening test. First of all, the screening test can be anything, not just a physical examination or imaging technique or blood values, but also a question. For instance, the question, are you a smoker or not? can change the probability of the person being a lung cancer, having lung cancer. Also, characteristic of gender is already a kind of screening test. So often you have to do a combination of different sources of information. What are the requirements? Again, the validity and also the reproducibility of the test. It should be simple, it should be safe, it should be acceptable, and then we have the psychological effects. It should be not too strong, the so-called labeling effect. And finally, there should be an acceptable probability of a false positive test result. Very briefly, some of these things. First of all, the validity. From diagnostic epidemiology, we know that we can quantify the validity of this type of test, not only diagnostic tests, but also screening tests in terms of sensitivity, specificity, false positive, false negative result, predictive values, positive, negative. But this applies not only to the screening test, that is, for instance, the mammography for breast cancer screening, but it depends. It also applies also to the whole program in which this test is embedded. For instance, if you want to evaluate the validity of a screening program for breast cancer screening for women, it's not only the mammography that holds, but also the timing between two screening rounds. How the women are invited, for instance. That things determine the validity, so the sensitivity and the specificity of the entire program. Attendance rate, screening interval, and so on. And then the question is, what's more important, to go for a high sensitivity of the test or a high specificity of the test? And now we have this problem. If you talk about law and judges, they always used to stick to this principle, this adagium, in dubio abstine. If you are not sure that the person who is in front of you is guilty, abstain from giving a sentence. That's the principle from law. You should have proof that he is the one who did the thing, otherwise no sentence. In medicine, it's often the other way around, and it's increasing the other way around. If you have that, say this person is ill, you are so afraid to miss a case of disease, and especially with the claim culture that comes from America. If you miss a person before you know, as a doctor, you are for the judge yourself. So anxious to miss, overlook a true case due to the claim culture. But we sometimes forget that this adagium in medicine is especially for curative medicine, in which patients come up themselves with complaints and let know that something is wrong. They ask for help, for assistance, and we cannot transfer the same adagium to preventive medicine. It shows it again. This adagium actually means, if this is the test results compared with the true state of the disease, the gold standard value. If you don't want to miss anybody with the disease, you want to make this value, this C, as small as possible. And we want to increase the sensitivity. We want to go for 100% sensitivity of the test. But we know we can increase the sensitivity for the same test at the cost of the specificity. If we increase the sensitivity, there will be a decrease of the specificity. For instance, we can choose a different cut-off point to say there is an abnormal test result. So C is minimized, sensitivity is maximalized to 100%. Yeah. If we maximize the sensitivity, the specificity will go down, and therefore B will go up, this number, and the predicted value of the positive test result will go down. And this is a particular problem in a situation where the prevalence of the disease, so A plus C as a proportion of A plus B plus C plus D, is low, which is the situation of a screening test, screening in the upper population. So the big problem then is the low predictive value of a positive test result. And as a consequence, overdiagnosis, this might be risky, abusive, and also overtreated. And this shows something, for instance, of for breast cancer screening. And now we have breast cancer screening for women between 50 and 75. It used to be 50 to 70. But there are also quite much young women below 50 who contract breast cancer. And everybody may have a family member or a friend. And then you ask, why not this screening for this younger age category? There are two reasons which have been taken into this balancing of the advantages and the disadvantages. First of all, if you talk about breast cancer, you see that the incidence, for instance, for women above 70 is much higher than the incidence in women below 30, but you can also use figures for below 40 or below 50. A big difference. And there's another important thing, the ratio of benign and malign cancers is much different for young and older women. So for women above 70, 3 benign upon each malign cancer, and for younger women it is 60. It shows it, the ratio. And there is another thing. The main test for breast cancer screening is mammography, make an X-ray of the breast tissue, and until now we assume that sensitivity and specificity of the test are fixed values, but not depending on the population. But this is not always true, and especially for breast cancer, it has to do with the density of the breast tissue. It's much easier to detect with the same test cancer in older women than in younger women. In other words, the sensitivity of the test is much higher in older women than in younger women. So there are two reasons, until now at least, to abstain from a national breast cancer screening program and to broaden this program to younger women. A small example to show this, it's already old, but there was a plea to initiate a national screening program for colon rectum cancer. Now again there was a discussion of it already in the 80s, and there was a general practitioner who was in favor of this. He did a study in his own village, in his own practice, and he said, okay, we have the hemoccult test. And with this hemoccult test we can see whether there are traces of blood in the phages, especially older men. They should use this. Now, the problem with this test, this potential screening test, was the following. The sensitivity is extremely high, but as a consequence, the specificity becomes compromised. Also, if you are brush your tooth every day, this can be responsible for blood in the phages. Taking aspirins give blood traces in the phages. Eating meat or high fiber food the same. So many people will be detected as false positives. So this GP, he organized a screening survey in his own village, the village of Barmenhuizen. He invited all males above 40, there were about 1,000, and initially 78, they participated, and it was increased even to a higher number, 82. And as a compromise, they were allowed to brush their teeth for the period, but they should abstain from eating meat. And then this test was conducted 3 days after each other, 3 consecutive days, and if there was one abnormal result, then the test result was positive. 1 out of 3 tries. And this shows the results for this 830 men. 18 were found with a test positive result. Finally, after further diagnosis, only 1, if you have this colon cancer, if you have rectal cancer, and also it was concluded afterwards that this cancer could have been detected just by a rectal touche, not necessarily by the screening test. Normally, you have no follow-up. You don't do anything for the test negative results. So 812 test negative result. But finally, within 2 months of time, 1 false negative case was reported. Not detected by the screening test, but it appeared to be there later on. That was the total picture of the screening test. And you can have your own thoughts about it. This GP concluded. I have the strong recommendation to include this hemoccult test in the routine physical health examination, periodical health examination of male of 40 years and older. So again, very much stress in the sensitivity and forgetting about the predictive value of the positive test result and the consequences, for instance, for this 17. Then I have some words about the other aspects. For instance, this labeling effect, this psychological effect that should take into consideration. What has been shown time and again, if people participate in the screening program and the test result is normal, they consider it to be a health license, a certificate. So now I can do what I want. I've been investigated, I'm healthy, no problems. And also they forget about the false positives, false negatives, the probabilities. And the other way around, if a test result is abnormal, people they think, okay, now this was it. They adopt a sick role and also forget about the possibility of false positive and false negative results. So both a beneficial test result and an unbeneficial test result in screening test can have enormous psychological consequences and consequences for the behavior of the people involved. And there's another thing. I showed already this this whole body scanner, and it's in general a problem if you use a number of tests in the same time. And nowadays it's so easy to take a drop of blood and in the same sample of blood used for 10 or 20 different tests. If each test has a small chance for an error, false positive or false negative results, of the total test you get a normal, what we mentioned, chance capitalization. The chance that at least one of the tests will be abnormal, will be not good, whereas nothing is wrong, increases enormously. So in a routine health checkup with much more than one test, the chance of capitalization of false positive, also false negative test results. I have a few examples, but I think it may be better to stop here. What do you think? Maybe I didn't have a break?
No. No break.
Dat zei hij niet.
Skip the examples? Yeah. You can read themselves about something about breast cancer screening, how it's organized in the Netherlands, and still okay problems that we have with the interpretation, all the positions, and then there was a need analysis from the conference operation, and now there are still
Dan is wel
again
online.
about the efficacy.
Ja.
Dan ik hem
It's
misschien
even
wel
worse for
daar in de
prostate
bus
cancers related to patient of ASA.
Ja, wat?
Yeah, I will send them to the Carla.
Daar hoor je ook wel wat zien. Ja, dat is echt.
Kan hij eindelijk zijn koffie drinken?